This program is brought to you by Emory University.
As you can see on your screen, this week's speaker is Dr. Dandan Chen. Dandan is in her 4th year of fellowship in our basic science research track. She's originally from China, where she did her med school. She got her PhD at Michigan State, did her residency in the Mount Sinai system. And as you can see, is going to talk to us about a very timely topic. I have a feeling we might be hearing about this more than once this year. But she is first up, so she gets the pick of the litter in terms of topics. So she's going to talk to us about COVID-19 and cardiovascular disease. Dandan.
Thank you, Dr. Bidirctional, for the introduction. Good morning, everyone. Thanks to be here so early this morning. So today I will talk about the topic we show here is COVID-19 and cardiovascular disease, the bidirectional interaction between the COVID and the CVD. There's no disclosure. So since the end of 2019, COVID-19 has been rapidly spread as a global pandemic. And the data from the WHO showing as of like early September, more than 27 million confirmed cases of COVID-19 has been reported over 216 countries, areas, or territories, and resulting almost 900,000 deaths worldwide. And data from the CDC here showing the more than 6 million of confirmed cases and the 19,000 deaths across the United States. And the Georgia, unfortunately, is one of the has been mostly affected, and the case number has been growth rapidly since this May. And so we already know COVID-19 has been placed a huge burden to the public health. At the very beginning, maybe lots of us thinking it may be just a seasonal disease like a flu. However, now we realize COVID-19 maybe will be around with us for unknown period until the vaccine become like effective. So we will definitely encounter patients who present to the hospital or clinic, the COVID patient with cardiac symptoms. So in the next 1 hour, I'm going to review the topics regarding the major cardiovascular manifestations in COVID patients. And also we're going to go through the mechanism underlying the COVID-19 related cardiovascular injury. And the last, we're going to just briefly go through the potential cardio adverse effects of COVID-19 drug therapy. So just like this is emerging like a field with new progress every day. So I'm gonna try to just keep like an update as possible. So patient with cardiovascular risk factor like diabetes, obesity, and established cardiovascular disease they will present vulnerable populations when suffering from the COVID-19. So there is, I'm going to just go through 4 larger studies. The first one is a study including about 1,500 patients from the New York City and the suburb, and report about 56% of the COVID patients have hypertension, and about 33% of the patients have a diabetes, and about 11% of the patients have a coronary artery disease, and about 6.9% patients have a heart failure. And also, you probably can see this high bar here. It's a 46 of the patients. They are obesity with the BMI greater than 30%. And just to let you know, the prevalence of the hypertension, obesity, and diabetes in the general US and the European population is much higher. Another study was done from the Lombardy region in the Italy. The analysis about almost 1,600 patients with COVID-19. They require ICU admission, and also show the prevalence of the hypertension, cardiomyopathy, heart failure, and hyperlipidemic and diabetes is about 48%, 20%, 18%, and 70% respectively. Another large observational study included the cases from the European, North America, Asian, also show the hypertension, coronary artery disease, hyperlipidemic disease, hypertension, diabetes. It's quite common, like comorbidity in patients with COVID-19. And interesting, the study from the China. So they have involved about like 199 cases, and the prevalence of a cardiovascular risk factor in the COVID patient is rather low in a typical Chinese population. But this study, more than half of cases has been missing the data on the comorbidity. So, and also the study also show this is a summary from a couple meta-analysis showing compared with the individual without the comorbidity, the risk of death was significantly higher or greater in the patient with the cardiovascular disease, including in this category, including cardiomyopathy and CAD, and also greater risk for the hypertension and the congestive heart failure, diabetes as well. And the chronic kidney disease have the highest risk, and other like the CVA disease and the cancer history also can give you a higher risk of death. Meanwhile, you can see from here is a patient with a respiratory or immunosuppression status like a COPD or HIV/AIDS. They are actually not significantly associated with a greater risk of mortality. So currently, we still has a lot of things that I know about the mechanism, how the virus infects the cardiovascular system. But there is some like a hypothetical mechanism proposed to see how the virus infects the cardiovascular system. So I divide them into two mechanisms. One we call a directed mechanism. So basically, the directed mechanism is the COVID-19, the virus. The infection is the virus binding to the membrane bound form of the angiotensin converting enzyme ACE2 by a protein called S protein, usually expressed in the viral coat, and then they can follow by the activations by the TMPRSS2. And the ACE2 actually is expressed in all tissues, but especially represented in the lung, the heart, vessels, kidneys, brains, and gut. So on this theories, all these organs are potentially preferred target of the virus, and they could explain why we can see multiple organ failure or multiple organ presentations during the COVID-19. And this is a pretty busy figure, but for the left part of this the figure, we have been just demonstrate the direct mechanism I just mentioned in the previous slide. And the right half here is the mechanism I just called an indirect mechanism. So basically, the COVID infection, they can cause the cytokine release storm, and they can activate the immune system and result in the myocarditis and the myocardial damage, and probably can cause the arrhythmia and the heart failure as a clinical presentation. They also can activate the endothelium system, and they can cause a microvascular or macrovascular dysfunction. And they can feature as just mentioned the myocarditis, also the hypoxic injury, and can be present is a stress cardiomyopathy. And also if they cause endothelium cells dysfunction, they can cause ischemic injury, including type 1 MI, which is a demanded ischemic. Also, they can cause the right heart strain because the pressures from the pulmonary system, and also can cause a surge. So this picture actually just give you a summarize for that. So the disease presented with COVID-19 actually is very heterogeneous clinical course. They can range from the asymptomatic carrier or to the lethal outcome with multiple organ failure. and has a very wide variety of the case, like mortality range from the 0.7 to 67%. So basically, they can the respiratory tract is the most commonly involved organ system in this disease. They cause pneumonia, they cause ARDS. They also can affect the central nerve system, can cause the encephalitis, can cause people loss of like the taste and smell, and also can have some GI symptoms. Patient can present with diarrhea and the malabsorption, and also can affect the kidney function. We have the acute kidney injury and the electrolytes misrange, and of course can cause the vascular thrombosis events because of high coagulation status. For the cardio symptoms, it can be presented as like acute injury, like the myocarditis, stress myocardiopathy, heart failure, and arrhythmia. So here's a case may present as like a most common scenario of a patient suspect COVID-related cardiac injury. So this is a patient, she's 65 years old. She has a history of non-ischemic cardiomyopathy with preserved LV functions, has diabetes, hypertension. So she was diagnosed with COVID pneumonia about 3 days ago, but he not really like on any like a medication, just like a supportive care. So and then patient like the symptoms become worse, and she was transferred to us because with the respiratory syndrome. So when she's arrived, she has a leukocytosis with the left sheet, but her kidney function and liver function at the baseline. She also have like a elevated D-dimer. It's about like 1600. And the outside hospital lab showing at the very beginning, patient have a COVID is positive. Its CHOP level is like a 1.28, and then trend down to 0.6. And the BNP is elevated to almost 900. And here is her EKG, checks X-ray and the echo. So the EKG here actually showing is like a little bit sinus tachycardia. That's compared to the previous like EKG, there's no STT change. And the X-ray also showing the patient have this like some in the mid and the upper lung have some patches like opacity, looks like some atypical like multifocal pneumonia change. The echo, let me see if I can play. So this is an echo she had about 1 month ago before the admission, and this is an echo she had like on admission. Actually, doesn't look like the EF is reduced. Looks like a preserved. And this patient, based on the labs she has, like outside the hospital, she has a myocardial injury evidence for his COVID. So and also the study has quite established like the patient have a myocardial injury. They are independently associated with a high mortality in patients with COVID. And this is a study is published in the JAMA early this year. They have like around like 416 patients in China. So they found that there was almost 20% of patients had a cardiac injury defined by the elevated high sensitive like a troponin. And the patient with a cardiac injury versus those without a cardiac injury, they have like shorter symptoms like onset from symptoms onset, and shorter like from the admission duration from the admission. And the mortality rate actually is higher among the patients with a cardiac injury compared to those without a cardiac injury. So and most of the patients actually they can present as like non like specific symptoms like so this is the two like patients' characters from the two large like observational study. They are showing most of them present with a fever, cough, shortness of breath, and fatigue. And minority of the patient can be presented with cardiac symptoms as their primary presentation. can present with chest pain, can present with like palpitations, or decompensated heart failure, and even cardiogenic shock. And so the diagnosis about the COVID-related myocardial injury, including the multiple modality. So can be like you need the labs, EKG, or you using the different imaging modalities like echo, MRI, even the CT. And some of them some of these institutes, they will also do the endomyocardial biopsy to see any pathology change evidence. So here I would like to show you is like there was one study also published early in the JAMA this year. So basically they are using the high sensitive cardiac troponin, and the study showing so this the trope usually elevated in the early stage in infections, and the level is much higher in the patient with cardiac injury, and also the high level of the trope also correlate with the mortality. And so as a figure showing here, so if the trope level is greater than 0.04, indicating the patients have the cardiac injury. If it's greater than 7.8, it suggests a patient probably have a cardiac infarction. And also, as a limited study suggests different trope Chen pattern can help you to identify the sick patient. And they divide it into like 3 patterns. One is mild elevations. So usually the trope level is less than 99th percentile upper reference limit. And usually they will just like on the subsequent days, the trope level can be just a modest rise or fall. And the patient usually do not have symptoms of cardiac symptoms. And this pattern usually seen in the patient with COVID-19 with survive after the hospitalization. And the second pattern they call the moderate time limited pattern. And the patient could have like early moderate trope elevations. And in the next consequent days, the level can be just like trending down. And the pattern usually see the patients like it's suspect they have the myocarditis or stress cardiomyopathy. And the worst pattern is a progressive one. As a patient have a moderate trope leak at the beginning, and their patient symptoms getting worse, especially they probably have some respiratory failure, and the trope level will progressively elevated with other like increased biomarkers, for example, the dimer, or other like inflammatory markers like interleukin 6 and ferritin. And usually the patient's mortality is more than 50% in those populations. And also the natriuretic peptide BNP is also usually high in the hospitalization patients, as we're showing right here, particularly with the patients have elevated cardiac troponin level. So the elevations of cardiac markers actually associated with high mortality and poor prognosis. And then next, we're going to just like review the imaging and the EKG change in the COVID-19 with the cardiac injury. So most common EKG change, it will be like a sinus tachycardia and the non-specific STT change. So, and also this looks like the patient I just presented earlier. And most of the patients will have the EKG like this. And also, that's quite a lot of report or case report or like a small like observational study showing the diffuse ST segment elevations and the T wave inversion can with or without the PR depression and seen in the patient with the myocarditis. And here is the EKG from a patient. It's quite healthy. There's no past medical history, mid-aged lady present with the respiratory symptoms and have a low blood pressure. And EKG here showing the sinus rhythm with low voltage in the limb splits, and also have a diffuse like ST aggregations in the inferior and the lateral leads, and the ST depression with the T-wave inversions in the V1 and the AV1, and yes. And also her troponin and the BNP level were high, and this is her cardiac MRI, and showing she has like an increased wall thickness and diffuse biventricular hypokinesis change, and LV function was decreased about like 35%. And also the MRI also showing there's like a delayed enhancement extended to the entire like LV, access LV, and also can see some like a pericardial infusions. So this patient was diagnosed as like a myocarditis after he was confirmed COVID positive. And also, if you also can be presented as like a focal and like involve the lateral precordial leads ST segment elevation. So this is a patient actually. This is a study from like New York, and they are only involve about 18 patients present as like a STEMI like EKG, and all this most of these patients go through the cardiac cath, and they find out actually if a patient have like a focal ST elevation instead of the diffuse ST elevation, especially involve the lateral leads. Almost like 8 out of 10 the patients have a coronary obstruction. So for like a differentiation wide, if you see the focal ST change, you probably will think about probably patient have like an ischemia process ongoing. And also this is a pathology evidence of cardiac injury. So very few studies provide the pathology evidence for the COVID patient. So here I'm showing you the first autopsy series from the New Orleans. They have 4 patients. They found that the most significant the gross finding was the cardiomegaly and the right ventricular dilation. And the HE staining here is seeing some like the blue arrow shown here, some like a focal degeneration. And also another study from the Germany group, they reported like a 39 autopsy case with a patient die of like a COVID-19 pneumonia, and they seeing the show the brown staining here. They are showing the evidence of the virus present in almost like 60% of the patients. And the histology study showing most of the virus is located in the interstitial cells or the macrophage infiltrating myocardial tissues. They are not really like localized into the myocytes themselves. So this is the evidence can be provided like showing you the COVID-19 is associated with at least some component of the myocardial injury, and could be because the direct virus infections of the heart. And also another interesting study just come out like recently. Actually, they looking for the patients who has been recovered from the COVID, and they follow up the patients around like maybe 2 or 3 months after the COVID diagnosis, and these patients has been the COVID like negative after that. So they do the cardiac MRI, they check the trope level, BNP level. They also have some patients going through the endomyocardial biopsy. So they are showing almost 78% of the patients there's the cardiac MRI showing they have the cardiac involvement for like some like a cardiac MRI change, and also have a 76% of the patients has a detectable high sensitivity troponin, and also have a high level of the BNP, relative high level of BNP, even after like the COVID infections. And also they're showing the LV, like EF functions is lower and the volume is higher. And the MRI showing the patient also have like the late enhancement, and they also have about a quarter of the patient have a pericardial like involvement. So this study actually is like give you a hint, maybe post-infection, the COVID infection, they probably have a chronic like CVD. In fact, people probably will be suffering from the like cardiomyopathy and or the chronic heart failure. But so far, this is a very small like a study, and only have the data around like 2 or 3 months data. So a long-term like experiment or need to be like investigated for the long-term effect. And then we move to the COVID-19 and the arrhythmia. So the prevalence, so actually this is another study done in the Italy earlier. So they are showing here, it's about like 700 patients diagnosis of the COVID, and only have 9 patients have a cardiac arrest, and 25 incidents of AFib events have like 9 clinical significant bradycardia symptoms, and 10 patients have non-sustained VT. And the only and figure here, they're showing only the cardiac arrest were associated with acute hospital mortality. So we can see the based on current data, so the incidence of the fetal arrhythmia is relatively low, and only cardiac arrest is associated like the acute hospital mortality. And the possible reason for that could be, one is a direct cardiac injury. Another one could be the electrolysis abnormality caused by the acute kidney injury, or like the electrolysis misarrangement. And also could be the reason, could be the medicine which usage for the COVID treatment can induce like a QT prolongation, and they cause the arrhythmia. And then we are going to move to the management of the COVID patients with cardiac injury. So far, there is no guideline, particularly for the COVID patients with a cardiac injury, but there was several guidance from the ACC and the AHA and the ESC. So for the patient, they suspect like a myocarditis. Basically, the mainstay treatment is like a supportive care. And the troponin and the BNP, they suggest only order when you highly suspect the patient have MI or heart failure. And also if you have the abnormal trop level or BNP level, it can be considered it is the evidence for the acute MI or heart failure. So at the very beginning, a lot of people just order troponin and the BNP for every patient. But I think now they move towards to like you just for the patients you highly suspect the patient have a real MI or heart failure. But still, we order that because we want to get a baseline for that for the patients. And also CCTA is become like a preferred modality to rule out the commitment of the coronary arteries if there's no contraindications. And the myocardial biopsy is not recommended in the COVID-19 patients. For the heart failure patients, So they still recommend that we continue the guideline-directed medical therapy for the chronic patients, except for they have contraindications. And here I would like to add some topic about the RAAS blocker and the risk of COVID-19, because just the theories for the physiology, right? So the ACE2 actually plays important regulatory roles in the RAAS system metabolism, right? The angiotensin 2 to generate angiotensin 1. And the study showing in the animals, they're thinking the ACE inhibitor and the ARB, the angiotensin receptor blocker, they can upregulate the ACE2 expression. That one is the protein, the virus enter the cells. So people will suspect this could be increased risk of the COVID-19 if a patient taking the ACE inhibitor and the ARB. So in this June, in the New England Journal, they published 3 large retrospective study to evaluate the RAAS blocker and the risk of COVID-19. So here I'm showing you is the one, actually I showed their data earlier. It's a study from the Lombardy region of the Italy. So actually they are to investigate the patient, almost involve about 6,000 cases patients with COVID-19, and they match them to about 30,000 of non-infected patients according to the sex and age. And they find out use the ARB and the ACE inhibitor do not show any association with COVID-19 among the case patient overall, and among the patient who has a severe fatal course of a disease. And also another study is the study conducted in the European, North American, and Asia. They also including about almost 9,000 patients who had the diagnosis of COVID-19. So they also evaluated ACE inhibitor and the ARB on those patients. They subgrouped them with mild to moderate symptoms, critical or fetal symptoms. They also divide them into the female and the male and the age. And they find out among these case medications, ACE inhibitor and the stat is more commonly used by the survivor than by the non-survivor, but there is no association between the survival and the use of the ARB was found. And also the gender, also there's no association with that. Another study was done by the New York University Health Systems. They collected the medical records involved in about 12,000 patients, and they test the hypothesis to see if the likelihood of the positive COVID test results any or a severe illness among the COVID positive patients associated with any antihypertensive drug classes. So here I just show you the data about the ACE inhibitor or ARB. Actually, they do not show any positive association for that. So based on that, the ACC and the AHA-ESC, they recommended the patient should not discontinue the ACE inhibitor or ARB therapy out of the concern if they are at higher risk for the infections. So, and all the 3 studies just published again and support this recommendations. So, and then we move on the guidance for the arrhythmia. So in January, there's no significant difference between the management non-COVID patients, but in particularly a scenario maybe a lower threshold to start anticoagulation for the severe patients with a newly diagnosed atrial fibrillation, so a flutter. Usually we still go by the Charter score to decide the patient need any anticoagulations for the AFib. But for the patient we just presented earlier for the case, that lady has a D-dimer almost like a 1500. She went through the nucleus study and showing there's no pulmonary embolism. Also, DVT do not show she has like did not show he has like DVT. But we still start the patient on the anticoagulation, just given her higher high hypercoagulation status. So the patient was to start with the adequate. For the plan was like doing 4 weeks for that. And another important thing is we need to monitor the QT interval more frequently, especially when the patients they are on some QT prolonged medications. So this is like a steps how to reduce the risk of the QT prolongation. Basically, you just need to identify patients like a risk associated QTc prolongation to see patient have any like underlying problem with the like congenital long QT syndrome. We also need to review any QT prolonging like a drug for that. And then we try to correct the risk factor like the hypokalemia, hypomagnesemia, low level of the magnesium. And also we need to see if patients like have on any other medications. After that, we basically we would like to do like a baseline EKG. And if the patient have the QTc greater than 500 microseconds, they are at a higher risk for develop like QT prolonged arrhythmia and sudden death. And this also can be like, it would be better if you monitor the patients on the telemetry and more closely monitor the electrolyte balance. And the next few slides, I will go through the potential cardiac adverse effects for the COVID-19 drug therapy. So the chloroquine and the hydroxychloroquine, so even though they do not approve, they can decrease the mortality of the COVID patient, but still it's quite a few patients receive the therapy for that. And they have the pro-arrhythmia and the QT prolongation characters, and they can cause the TOSA. And also they also have a direct myocardial toxicity. They can cause the myocardial dysfunction. And also we need to watch for the drug interactions. For the CYP3A4 pathway, usually it's, they can have an effect for the concentration of the hydroxychloroquine. And also for the cardiac, like we are using a lot of the antiplatelet medication like a ticagrelor, and the anticoagulation medication like a rivaroxaban and the ampicillin. They need to be adjusted dose if you are consider the CYP3A4 pathway interaction. Also for the warfarin, they metabolized by the cytochrome P45. So also need to be keep a mind on that and adjust the dose of warfarin dose. And also other common things about the high dose of the steroid treatment will become a challenge for the patient with heart failure. And this is the potential cardiac side effects. And here, this is a table. Actually, they are summarized like the medication now is using for the COVID therapy. They divided into like antibiotics and as we know, like azithromycin and this kind of macrolide category medications. They have they are known. They have prolonged the QT interval. and they also have the interactions with the CYP3A4 pathway, and also the under investigational drugs like the remdesivir. They know the cardiac effect, but the other medications like protease inhibitors, they have a prolonged QT interval. They can cause conduction disorder and heart block for that. So this is my last slide. So my take-home message for that is the cardiovascular comorbidity and the risk factors such as hypertension and diabetes associated with a high mortality in patients with COVID-19. And the COVID-19 can also induce cardiovascular manifestations, including myocardial injury, myocarditis, arrhythmia, heart failure. And among these manifestations, myocardial injury has been independently associated with high mortality among the patients with COVID-19. And the medications, so it has been proposed to treatment for the COVID-19 may induce cardiotoxicity and arrhythmia. And thank you, and I'm open to the question.
Thank you, Dandan. That was a very good review. Any questions from the group? Dandan, I have a question just in terms of sort of long-term therapy for, I mean, obviously we don't know this yet, but what would sort of be your thoughts, or what have you seen on sort of long-term medical therapy for patients with COVID-associated myocardial injury, whether it's antiplatelet therapy, you know, standard heart failure therapy, et cetera?
Yeah, that's a good question. So again, we don't know for sure for now, but I'm thinking based on the evidence, like especially the recent one they published about the they seeing the still have ongoing like progress of the myocardial injury even after the COVID recover. So for this patient, I'm thinking we need to more closely like monitor like a more frequent outpatient follow-up, especially the patient already have like underlying cardiovascular disease, and then we probably for them besides continue the gold standard management, like a medication management for the heart failure. For this patient, I will like a more close monitor for anything change about their symptoms, volume status. And in terms of the antiplatelet treatment, so far there's no, I did not see the evidence to show like upgrade escalate the antiplatelet treatment for the patients will have a benefit for that. So I'm thinking we still go to the guideline we know for the ACS patient, for the stable angina patient. I'm thinking probably at this point we still go through the same regimen for that. And also for if the patient have arrhythmia, their diagnosis during the COVID, so usually they will reassess the patients after they recover to see if the patient need any long-term anti-arrhythmia medications. But just like the slide showing, most of these patients actually they are with the arrhythmia. Actually, the prognosis is not bad.
Dan, I have a question from Dr. Dickert. It has gotten some press in the context of sports, but what are the recommendations regarding activity, et cetera? Patients have elevated biomarkers or other cardiac involvement in the context of COVID-19. Yeah, this is going to be my other question, sort of recommendation. Again, I will express the caveat that there's a lot of, I don't know, we're not sure, but sort of based on what you've seen, what would be your recommendations in terms of resuming, what if either a patient resuming recreational activity or even a young patient resuming competitive sports?
Wow, this is a great question. So actually, I don't know the answer actually. So, but I will look it up. So I did not check for that.
I mean, I'll just give my 2 cents. I mean, right now, I think sort of the guidelines are, if you think there's been evidence of myocarditis, it would sort of be in keeping with what the general guidelines are for myocarditis. So staying out of competitive sports for a period of, 3 to 6 months, recreational exercise sort of, and I'm probably getting this right, I think, but sort of progress is tolerated once full resolution of symptoms occur, as long as they're no longer having chest pain or signs of active peri or myocarditis in terms of, enzyme elevation, chest pain, EKG change, et cetera. Once that's resolved, sort of progress is tolerated sort of slowly, I think is probably the default recommendation at this point. All right. Well, if there are no more questions, then thank you, Dandan. Thank you for everyone for tuning in, and we'll see everyone soon.
The preceding program is copyrighted by Emory University.